Hello, everybody. I'm BJ Miller, palliative care doctor, Mettle Health. This is the leftover questions from today's webinar on disability, the myth of disability. Over to you, Sonia.
Thanks, BJ. Okay, so the first of two questions is, does neurocognitive disorder meet criteria for receiving palliative care? The result of my neuropsych assessment earlier this year came back with the diagnosis of neurocognitive disorder, and my ADL management has become increasingly difficult. Now, with the official diagnosis of neurocognitive disorder, will I qualify for palliative care in some form?
So the short answer is yes. I mean, remember, hospice, probably not hospice. In your question, I don't have a sense of your prognosis. So hospice, some expert, some doctor somewhere has to say that you've got 6 months or less to live to qualify for hospice. But palliative care, the big brother of hospice, has no time limits. So absolutely you'd qualify for palliative care in terms of sort of by the letter of the spirit of palliative care. Now, the trick is depending on where you live, depending on what health system you're in. So individual systems may have their own rules for who gets access to palliative care because it's a limited resource, because we don't have enough palliative care trained clinicians and programs in this country. So whatever's available locally to you, they may have criteria that you have to have a certain prognosis, or they only see certain diseases. But just know from in terms of officially speaking, the spirit of palliative care, you are absolutely welcome into the fold at this point. So I would push you to ask your neurologist what the palliative care options are within your system. You could also try calling your insurer to see who they are contracted with. Or you could go to the website getpalliativecare.org and put in your zip code. There's a directory in there, and up will pop local programs in your area. So hopefully that answers your question. The short answer, the long answer is yes, you should qualify for palliative care. Hopefully your local resources agree with us.
Okay, and the next question is in relation.
One more thing there.
Of course you can. Yes.
I mean, again, these webinars are not meant to be sales calls for Mettle Health, but this is a reason why Sonia and I set up Mettle Health. So if you're not able to find local palliative care programs and you still want this kind of care, please don't hesitate to reach out to us at Mettle Health. So Mettle Health, METTLE, mettlehealth.com. You don't need a doctor referral. It is out of pocket, but we do things on a sliding scale, et cetera. So if you can't find local palliative care resources, don't be shy visiting us at Mettle.
Okay. The next question is about medical professionals, and this person said, I wonder if part of issues with disability in the medical system is medical professionals being oriented towards fixing or curing, and that a person living with a disability can't be quote unquote fixed. Related to this, I wonder if you can speak to the intersection of end of life concerns and disability.
So yeah, so I mean, there's so much right and so much wrong with the medical model. It's a clunky, unnuanced behemoth. It is, if you ask me and a lot of people in the field of palliative care and a lot of patients and a lot of clinicians, I mean, the system just doesn't work well for anybody, for most anybody, no matter which side of the ledger you're on. So yeah, this does get at the shortcomings of the medical model of looking at everything as a problem to fix. And if we can't fix it, have a good day, good luck out there. There's nothing more we can do. That mentality is all over the place, subtly and explicitly. There are efforts, palliative care and others are pushing to sort of revamp medical education and how the medical system works. I think we are overdue for a federal, national sort of overhaul of how medical education should be designed. The last time we did that was 1910 with the Flexner report. We are overdue. I would like to see healthcare design from the bottom up again. And we have to decide, are we here to support, is patient care here essentially to support research or vice versa? And if patient care is the tip of the spear, well, when does our job end? Do we see ourselves at being involved through problems that we can and cannot fix all the way to death? A lot of us would say that is our responsibility, and services should suit. But we need to ask ourselves these big sort of organizing questions at the structural level. So sorry to keep going on and on, but that's my answer to that question. This is a big problem. Um, Now, what was the second half of the question, Sonia? Sorry.
No problem. It was, is there an intersection of end of life concerns and disability?
Well, yes. So there are issues that come up around end of life care, just along as well as any other sort of mode or period of care. So one of the great things, hospice is relatively well suited as a service that generally comes to people wherever they live. So issues of accessibility are less of a problem, because hospice will come to you if you're able to live in a place that you're safe and sound in. So hospice has an advantage in a way over the rest of healthcare for tending to disability issues. As a spirit of care, hospice tends to not abandon people because they're not fixable. It's the whole mode of care. So I'd imagine you would find a much friendlier experience for disability at the end of life. But that's a relative statement. We still have the issues of how people are trained, the socialized around issues of disability, how we accidentally sometimes present with a sort of a pitying affect rather than an empathic one. It's not a perfect, I'd say hospice and end-of-life care would be better than the rest of healthcare, but still probably has a long way to go. And I think just in terms of the spirit of a life completion, understanding a person and bearing witness for a person who's dying, understanding what anyone who's gone through in a life of living with disability is a part of that bearing witness. But palliative care and hospice guys should be really good at that, because the job is actually listening, not pretending to be experts about situations they haven't been in, but rather to listen to people share their stories. So long, kind of convoluted answer to your good questions. I hope that hopefully somewhere in there is an answer.
Okay, and that's all the questions we had. Thanks again, BJ.
Thank you. Okay, bye.